Welcome to How To for Dermatologists. I'm Neil Bhatia, your host, and this is a series on how to take some pearls from the experts and make them into our practice and how to do what's best for patients. And I'm with the fabulous Deanna Glazer and His Highness, Dr. David Pariser. And we're going to talk about how to choose effective therapies for hyperhidrosis. And seriously, you guys are the A-team for sweat, if you will. Deanna, walk us through the algorithm and how to approach the hyperhidrosis patient.
I think you start with a good history, good physical. You let the patient identify what areas they're sweating from, what they've tried. And then I think the key is to really try to manage with focal therapies if possible. Treat only the areas that are bothering them. And there's topical agents, botulinum toxins, antifreezers, there's all kinds of things that we can discuss, but try to get those focal therapies optimized.
And what do most patients come to you having tried already?
Usually they've tried the over-the-counter antiperspirants, they're frustrated, they may have tried some products that they've gotten online, and really they're just desperate for help. I mean, they are really desperate to get the confidence back that they want and to be able to deal with their lives.
Yeah, go ahead.
Well, I think it's important to say that although axillary hyperhidrosis is what we're focusing on most of the time, it's really only one of the areas that bother patients. Other areas, palms and soles, inframammary, infragluteal areas, even the face and scalp are real common problems, and we sometimes tend to overlook those.
So when do we have to distinguish between excess sweating and true hyperhidrosis?
So you want to be sure that a patient is not suffering secondary hyperhidrosis from some other cause, something neurologic, a side effect of a medication, endocrine cause, etc. That usually can be determined with simple history.
So I'll ask you both, where does antifreezis still fit into the paradigm?
Well, okay, for hands and feet, palms and soles specifically, iontophoresis really is the #1 go-to treatment. It's effective in people who can tolerate it and who have the time to do this, 20 minutes 3 times a week or so. It gets a little cumbersome for some people and it may not be applicable for everyone. But for palms and soles, it can be a real benefit, and it's the most cost-effective way to treat palms and soles.
How do we get a patient started? Like, is this a prescription item, or what do we do to get the patient started?
It's a prescription. In my office, we try to get it covered for them. We write a letter of, prior necessity for them. And if you can get the patient to get through those first couple of months, 3 times a week, many of them can maintain just once a week. And so that's doable. It's more manageable. It's the first couple of months it's tough.
And when's the transition to botulinum toxin?
Well, botulinum toxin, of course, is approved for axilla, but you can use it anywhere. I think it's a great option. It's expensive, of course, compared to some of the others. But what patients like about it is it's injected. They come in twice a year, usually. It lasts about 6 months. But as a clinician, I think what we have to do is give the drug where patient is sweating. So starch iodine test is going to really help you identify where they're actually sweating from so that you can deliver the drug there. And you can follow them up with a starch iodine test afterwards. Inject right where the sweat gland is, and that's down into that subcutaneous fat dermal junction right there.
And how do we get that reimbursed? Are there any pearls for?
Well, if you work hard enough, many times you can get reimbursement for botulinum toxin injections. Not always. But if you really try hard to get it for your patients, you can often do it. But there are some people some payers which will just not pay for it, and then it becomes a cash pay service.
And when do we turn to the systemic therapies?
Well, systemic therapies can be monotherapy in a patient where there's really no other option due to access or cost. But usually it's secondary to something else. You might do botulinum toxin and give a systemic anticholinergic. And also for the patient who has multiple areas of multifocal hyperhidrosis, it might be more appropriate to use a systemic agent.
And we're thinking about glycopyrrolate, or there's some newer options?
Yeah, I mean, glycopyrrolate, oxybutyn are 2 that are most commonly used. I think it's good to just start at a low dose, gradually increase as the patient starts to develop efficacy or side effects. And then again, if you can use it in conjunction with other therapies, I think that's very helpful.
And what's in the pipeline for these patients?
Well, within the next year, we're going to have a topical anticholinergic preparation in a wipe, a little towelette wipe. It will be approved most likely sometime this summer, and it will be labeled for use in the axilla. We all can't wait to get a hold of it and use it in all these other body areas as well.
Absolutely.
And it will probably be a first-line treatment for those folks who fail on antiperspirant therapy, over the counter or prescription.
And what about anything else orally? Anything else new coming?
I don't know that there's anything new coming. I just think that there are other drugs that you can use as for specific instances, like you can use a beta blocker for somebody who's got an event-related type sweating. They know that every time they get up to give a talk, they start sweating. Give them an Inderal tablet about 30 to 60 minutes before that. Clonidine sometimes is helpful for craniofacial sweating as well.
Well, that's excellent. Well, Deanna, David, thank you guys for all the pearls. This has really been a good discussion for our audience. And this is wrapping up another episode of How To for Dermatologists, and we'll see you next time.